malignant, but we're pretty sure that it's not going to be of the melanoma, then these are the things that we can see, what we can do, and how we can find of a positive of a prognosis. Okay? So we're going to talk about the basal cell carcinoma. We're going to talk about actinic of the keratosis, Bowen's, and then one of the worst ones on this list is the squamous cell of a carcinoma. I know that we did speak about all 4 of these as we were going through the first lecture last week, talking about this looks like this and it's benign, but it could be this one, and it could be this one. So again, we're going to see it a lot on here. Refer to derm, refer to derm, refer to derm. Okay? BCC, most of the common skin cancers, and it can get into a malignant neoplasm. Sun-induced, right? Highest risk, intense, intermittent exposure versus equal dose of continuous exposure. As I said, we can have some of the malignant proliferation if it is inside of the basal layer of the epidermis. What would cause the most important risk factor of the BCC? Inability to tan. So it's of a Caucasian, of a light skin, that if it is exposed with all of the things that we talked about with benign, of the sunscreen, of the coverage, of those things, the phototypes, right? So we talked about ethnicities and races, who's at of a higher risk of having these things. What do they look like? They can look like it's got umbilicus, if it's got some of the dome shaped, if it's having some of the smoother stuff, basically anything that looks abnormal, we can test it ourselves or we can refer. I told y'all how sometimes if you're seeing of a patient because of a knee pain and you see something like this, be like, hey, how long has that been there? Have you had others, to do those things? Otherwise, it is the patient who's walking in being like, I don't know what the hell this is, yada yada. Dermitis. Slow growing and generally asymptomatic. It is only there because it is seen, but it's not there because it's hurting. Pink skin color, pearly. Firm, dome-shaped, ulcerates the rolled of the borders, or it could just even have some of the vesicular aspects in and around it with the talent. Quote unquote, it's oftentimes referred to as a rodent ulcer. So it's been bitten all up. So if it's nodular, those are the things that we see it. If it's only the superficial, then we can see round, oval of a plaque, which is one of the pictures that we saw there, bottom on the left side. And it's circumscribed, so you can see where the areas are at. Presentations. Typically, this is of our older folks, so if they're over the age of 40, it would be one of the things there to look at. If it is of a patient who's coming in because they want to know what it is, then it could have been itchy, or they thought that it was like a zit, so wanted to squeeze it out, but instead of having some of the pustule stuff, it's then some blood. So there, it's talking about the bleeding or scabbing sore, heals, but it doesn't go away. It comes back. Locations, if it's of the nodule one, we're going to see that on the nose. If it's of a superficial one, which is of the plaque, of the trunk. So nodular nose, superficial trunk. So what could be some of the things that would cause this to have malignancy? BCC advances by direct extension and destroys normal tissue. So it's not just right there at that spot. It can get out and around it. Long-standing lesions replace vital structures throughout spreading. Untreated, it can destroy whole side of the face and even subcutaneous tissue. However, BCC almost never spreads on out. It can, but it's not of the most common. Usually it stays there and it doesn't metastasize. Pictures of it here, we can see of the nose. Nodular nose, so that is a nodula, 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 nodula. We were talking about the fact that it's not metastatic, but if these are left and it can take over, and we're seeing of the other of the three pictures that it is spreading. Management. That one right there is what we're going to see over and over. Referral to derm. Okay. Detect early, so you can do chopping it all out. You can do of a punch biopsy. You can do those things, or send it and let that specialist do it. Mohs. How many of y'all have heard it, seen it, or I knew that arm was going to go up back there? The dermatology expert back there. So the Mohs, that is oftentimes, if it is of a BCC, if it is of an AC or of an SCC, that is on of the face, and the dermatologist has to do the local anesthesia. And then they're going to be taking some thin of the layers off, putting it onto of a scope. If it's empty down at the bottom, then all of the cancerous malignant stuff is gone. So we suture it up and off they go. But if we still see some of the cells there, then we have to hack it again, look at it. Hack and hack and hack until you can see on of the layer of the skin that it's all empty. And because of the fact if it was there for months or years, you almost had to take off their entire area. So it's no bueno. If we're doing these things, yes, obviously the prognosis is very good. We have these individuals, and for at least the 3 years after we do excision, we would want to do of a total of a body, every year. Okay, so if I were to cut it out right now on March 18 of 2025, yearly up until 2028. Then I'm going to look at it once a year. Or the dermatology. We don't have to. I just described it all, and here's one of the pictures of it. As you can see, the top of the picture on the left, it's already showing you where all of that stuff is. So on step one, the dermatologist takes the third layer. He looks it under of the scope, and it's just all of malignant cells. So he's got to do it again. Look. Again, and look at, and so then you can see on the step 5, he is not seeing anything on the scope, so he can stop and then start to suture it up. These are the pictures there, so we can see that's a little bit nodular, so it's on the what? It's on the nose, in and in. There we can see some of the spider stuff, right? So the telly is all up and around, nodular. Same thing. Plaque. On that upper lip, and I'm not a dentist, so I don't want to say what is going on the teeth. We're focused on the skin, okay? This next one, two or like how long was that there? That's going to take a lot of the surgical excisions. Even worse. All right, so here is what the Mohs is. You can see how there's the eye, and we've got some of the nodules up and underneath there. So what the dermatologist does first is there with B. So you can see how he or her take one of the layers and hope that it's all of it. However, we can see that in C, they're having to do it again and take out more and more and more. One of the things that I remind individuals that yes, all of the cut is here, then that skin just folds done and out so that then it can be put back up once they get everything out. Once it's all cleared out, if they can't use it again, then they'll have to take the skin graft from somewhere else to make it look how it should. But with all of the suturing here, you can see how it's only on the top area, so it wasn't sutured all the way around like that. Here we go again. It was a thin layer, and it's not just good to go. So then they have to do that up until it's all out. Sometimes it can be an entire area. If it's been there for years and years and we haven't done anything, then you can see that it's spread. So that, I'm pretty sure this is the same patient. That is what it looks like there. And then this is after it's all put back. All right, so that is all of the BCC. So that is the basal. Now let's get into the AK. So the AK, it is similar. It's equal to SCC because of the fact that it is combined or confined to the epidermis. Pre-malignant. How does this happen? Chronic of the UVB, right? So that's our middle one, UVB. Fair-skinned, again. Superficial, that is limited to the epidermis. Localized rough feeling to skin of the erythema with scale. Hyperkaryotic lesion on ears and of the dorsum of the hand. Adherent yellow scale that is sharp. It could just be just looking like those horns that we talked about, but it's more advanced. Okay, we have to, if it's coming up as of an AK, or if we saw it a benign aspect, we also have to, if it's a horn, let's take out SCC just to make sure, rule it out. SCC is the worst one. Location of an AK is head, neck, upper trunk, extremities, everything that you would be on a beach and you are just covering up stuff is not on there. Everything that is not is there. If it's on the lower lip, that's cheilitis. That is what we call it if it's on the lip. Elderly, increase with age, increase with all of the sun exposure over and over, with all of their wonderful travels to the nice places in the world. It's always been some of the older ones, but because of the fact that all of us, well, not us, all of y'all young individuals go on spring break vacations, and the sunburns are all over the place, and you got beautiful light skin pictures on your back as you pass out and fall on the beach. And yeah, anyways. AK, if the lesion is on the superior aspect of the pinna and tender, we have to think about of the CD and H. Excise it. And yeah, cover it all up, protect it. Don't be in UFC and have them all enlarged. Everything in dermatology, if we're talking about the skin benigns, the pre-malignant, malignant, if it's a melanoma, why the hell haven't you protected your skin for years and years and years? And that's the reason why you get these things, is because of exposure. TBSE, if we're looking at one, then we're going to look at it everywhere else to see if you've got more. Few, if there's only some of locations, then we can do some of the cryo. If they have it all over, then of the FU. Multiple lesions, FU, okay? We can also use some of Aldara, which is of the cream, to put that on there, and it breaks it up. If it's thicker, then shave it off, get it out. Prognosis of the AK, 10 to 20% will develop to SCC if it has not been talked about, touched, studied for over 10 up to 20 years. So if that individual, you ask, how long has it been? Well, I'm 50 and it's been there since I was 30. Okay, well, it could have been good, but now it's probably bad. So, yeah. The potential there, we can see it's pre-malignant, which was bolded and underlined as we start this. It was pre, but then if we're just letting it go and it starts to spread into the dermis, then yeah, that could turn into the SCC. There's some of the pictures, right? So we can see how it's of a plaque and it's got the crusty stuff to it there. This individual has them in several locations. We can see with all of the atrophy, this is an older individual's. Of the face, I would say that I would be concerned with the ones that are on of the upper cheek, but also up there on of the forehead. I would be concerned about that. Again, it's like that yellow of the crusting that is there. That is over there at of cheilitis, right? So we can see that is of an AK. Of the corn, of the ear, horn, corn, and same thing. But that is the upper of the ears. So let's go ahead and get that out. We talked about if it is something that is of a single lesion, then I could treat that with which one? Of the cryo, right? But if it's multiple ones, then I would use FU. Okay, so here she has it on the upper face where you can see all of the redness. That's where all of the sites were at, because as you use of the FU, it inflames, it does all of the erythema, and then afterwards, once it subsides, then it's going to make it look beautiful. I'm pretty sure that y'all's answer is going to be to press on, but I've got about 25 slides left. Would you like to take a break now? Yeah? All right. Let's take a break. Afternoon with Mr. Ruggiero, and then the most amazing pro dev that all active duty go to, but these civilians run away. Okay. So, SEC, this is the one that is of the things that it could convert. If it's left and it's not doing anything, then it could just get worse, right? We talked about how it goes through the steps. So here's in situ, right? So it's the Latin phrase of on site and in a position, right? So you can see where it's at. Is it of a border, right? So we're going to talk about the ABCDEs as we go into the rest of this stuff, okay? So this is of keratinocytic dysplasia involving full thickness of the epidermis without infiltration of atypical seals into the dermis. So this is not of a melanoma that it starts at the top, but then depending on how far down it goes, whereas this one, it infiltrates, but it's not going to go as deep. The melanomas, they can all the way go down to fat cells and stuff if it's really, really severe. Morphology, slightly elevated red scaly plaques, okay? It's got well defined of the borders, which you're going to see in the next lecture, to where those ones are just all out and around and just look like they're on of a tour, okay? Of the locations, if it is of a woman, usually it's in the lower extremities. With men, it's the scalp and ears. Why? Most men don't have hair that covers it all up, whereas beautiful hair blocks all that area. So, yeah. So the bones, right, of the presentation. So it's later in life. It's on the sun-exposed skin, and it's not of the localization to visible lesion laterally and extends down the follicles. Okay. So it's the spread of that area, whereas if we compare it to AKs, which we just talked about, that is only the epidermis only. Treatment, small lesions. If it's small, then we can electro, to taser it or to curettage. We can do some of the cryo and then excise it if it's small. If it's large, then we're going to get into more of the significance of the treatment. So 5-FU cream and of the Aldara, which is a generic term, imioquimod, Quamina, imiquam, no, whatever. You know what it says, Aldara. All right. Potential. So it's at a low grade to get into malignancy. Slow growth, but will progress into invasive SCC. So this is specifically of the Bowens that is a part of SCC. So they are partners in crime. Every 6-month follow-ups required. So if it's oftentimes, if we were to chop it out today, 6 months after that, we're going to bring them back because they're at a risk of recurrence. So we're going to do those things. So we can see there that's on of his middle finger. That is one of a location. I mean, it's a little bit larger than of just for the cryo. So if it's larger on a middle finger, FU. Okay, come on. That was funny. FU. What are you gonna treat it with? FU. There it is again. As we can see, it's not like of a circle. It's a plaque, but it's got none of the border, right? It's just all around. Or asymmetrical is the word that I meant to see, because it does have a border. More of it right there. Of the dorsal aspect. Again, we talked about how this is a part of in situ, right? So it's SCC, a lighter or a beginning aspect there. Talked about with the Bowens how in uncircumcised elderly males, it could also be the vulva of the elderly of the females. And these are some of the things that we did talked about of the Bowens. I think last block we did talk about the Bowens when I was going through all of the bacterial, the viral, the fungal and stuff, and we saw some of the pictures that were on the penile shaft. Presents with moist, red, smooth, slightly raised plaque, which is what I just said. We talked about how the viral stuff, we showed some of the pictures, and it was because of the HPV. Treatment, FU, Aldara, or laser. We talked about the fact that if it is the queer rat, that could be of an oral aspect there. So we can see those that are up in the middle of the picture. So you can see all of the plaque and of the redness. Erythroplasia. That is on the vulva, as well as on of the glands on the right side. All right, so that is part of the SCC with the Bowens. It's got some specific things that are to assigned to that. Now let's just talking about SCC itself. Second most common skin cancer. Second most, and it is at a high risk of the metastasis. So what caused it? What are the risk factors? Pretty much everything that we have already talked about. Sun exposure, sun exposure. This is of the UVA, UVB, And the most common pre is of the AK. So an AK left alone could turn into of an SCC. The other of the risk factors, we just talked about the Bowens. We have talked about the radiation burns, of the irritation of infectious process. So we just talked about the HPV 8 immunosuppression, inflammation, and arsenic. So what have they been doing for their careers and their jobs and all that kind of stuff that could have exposed them to some of the things that was a risk factor? Red, scaly, persistent, deeper involvement. They could have of an ulceration, but not every one of them has to. Hypertrophic lesion with ulcer or hyperkeratosis, so that would be of the horn. Okay? If it's a horn, let's go ahead. If it's on your lips, that would be of an ulcer with of the induration, like it is on that lip right there. Sun-exposed skin, scalp, backs, hands, superior surface of the pinna, and if it's happening because of Bowens, then it can be anywhere. Management. Small of the lesions arising from of the prior AKs, then we can curettage or just fry them. Largers of excision. One of the things here with the SCC that was not talked about with the AK and the BCC, lymph nodes. Examine the lymph nodes. And why? Because this could be spreading out and it could be traveling around with the lymphadenopathy. Follow up every 12 months for life. Could it be malignant? Yes, malignant. The prognosis here is talking about aggressiveness, varies with the cell differentiation and the locations of the lesions in and of themselves. Prognosis. How much of the sun exposure did you have? Because we can have some metastasis, right? That could just be overall. If it's going to be some of the spreading, then it's the lips that is of the greatest one that it could venture out into the wild blue yonder. SCC. The dorsum of the hand, lips, more lips, of an ulceration type thing. Please know that just like with all of the dermatology of the pictures which we use for the testing, yes, I can show of a picture, but it's more of the stem and of the vignettes that are going to push you back and forth, because I could just look at one like this. Is it benign? Is it this? Is it that? Da, 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 da. So I'm just going to have you know this picture exactly is SEC, because it could look like a BCC. So it'll be of the questions that will move you around with what we should do. Nodular, it's looking like it's on the scalp because of the hair, but could be not. I don't know what an otoscope is going to look like if he's having ear pain, because we're probably not going to see anything. There you go. All right. So we talked about the ones here, right? BCC, AK, if it's left alone, it can turn into SCC. Part of the SCC is the Bowens, which also could get into that way. So now, let's go to the last one for today, which is talking about malignant melanomas and the atypical nevus. We have about the 30 minutes, and it's 84 slides, but half of that is pictures and all of the ABCDE of us to know those things, okay? So we're going to talk about the atopical and dysplastic and the melanomas. All right, so we're going to start off with the one here. We've all seen of those ethnicities, right? So one is all the Celtic. It's all of the Caucasian and everything, and then it's going all the way down into the end, and that's more the African American, Hispanics, and things there. With dysplastic, oftentimes we can see some of the skin manifestations around the puberty ages, and then it just stays and it grows up until they get into their 40s. This is equal with both of the male and of the females. Morphology greater than 5 millimeters, either flat or flat width of a raised center, would be known as a fried egg. Look for ABCDEs. So it's asymmetrical, border, we're going to get into all of that here in a bit. Shades of brown and pink, because of the fact that these are going to be irregular and indistinct of the borders. Like, it's hard to see. I think it's there, but part is pink, part is brown. So is that the border or is it not? Where can we have these things? We can have it on of our back. We can have it on of our upper and of the lower limbs. But specific with this one, it can be inside of the sun protected areas. So if you're seeing this occur on of the breast, scalp, of the buttocks, and of the groin, those things that are not exposed to the sun, then you would think about this as a potential of a diagnosis, okay? What are we going to be seeing here? We're going to see at least 3 of the following areas, right, or items. So if diameter is over 5 of the millimeters, that's 1. Ill-defined borders. So I just talked about that, to where it looks like it's pink and brown, but is pink of the part of it, so it's hard to see the borders. Margins, it's up and down, looking like something slammed on a floor and just glowed out. Varying the pigmentation. Presence of papular or macular component. So 1 or 3 of those things would lead us into knowing those things, and I can promise you that if we're looking at any of these lesions, the top 3 are automatically seen. Again, this is just explaining to you what is of the age, what's the size, what's the color, are there some other things specific to dysplastic. Treatment, excise it, but not only just at what we can see, we're actually going to do it a little bit beyond that, because of the fact that we don't see what the border is. TB SA every 6 up to 12 months. Oftentimes, most of the patients who have had it cut out, they want to be here every 6 months just to make sure that it's not worse than that kind of stuff. Unless they don't care. We will, like with every patient at the end, we have all of the recommendations, right? So it's due for your pap smear. You should, you know, da, 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 da. Well, in here, it's talking about the fact of the sun exposure. How do you examine yourself? What are you going to be looking at? If you are having this, then you will, like, say, if I'm 40 and I have a 12-year-old son, and these ones right here can start about the puberty spots, then I could look at those things or show him or her some of the pictures. If you see one of these things, let me know. So that is all over the place. Some of them aren't really anything at all because they're light or it's small, and more of the focus is on of the larger ones without irregular the borders, you know, all of the colors there. More of them. We talked about the ABCDEs, so we can see some of the most specific ones, which I didn't plug that in, but we can see how right here, is it connected or is it two? Is of the border going up and down? Is it, you know, here it's a lighter color, a darker color, so it's those things. One of those just looked at individually would be like this. That one there has slight of a nodule attached to that. Just like that one right there. So that is all of the dysplastic venitas. Now we'll get into the bad boys. The bad boys. Malignant melanomas. Okay? That is the 5th most common cancer in men, 6th in the women. It's specifically, I'm talking about it's a derm cancer, so that is number 5th, whereas we could have a cancer anywhere in our entire body. So this one is number 5. Median age, 57 years old. Then afterwards of death, 67. Males are 1.5 risk higher. White, the Caucasian individuals, 10 times greater risk than of the Black, Asian, and Hispanic. So 10 times a greater risk. More of the risk stuff here, right? So we're at of an increased risk if they have the history of the moles, of the family history, of some previous some skin cancer, of congenital nevus, history, family history again, or some immunosuppression. Large number, atypical of the nevi. The chronic tanning with of the UVA or of the puba. It's talking about what those statistics are. Sunburns, you've had those annually. That could be the reason why. The freckling of the fair skin, because they cannot tan. So that is the number one that we're going to talk about. Ginger, blonde, atopical, which is what we just talked about a little while ago. All right, so risk factors. That is of the phototype of 1 or 2. We just talked about what those ethnicities in regards to their phototypes of the hair. With everything in here that we've already been talking about over and over again, of the UV exposure. So if they've had the skin years and years and years, then it could then turn into all of detrimental risk factors that could cause this to happen for us. That is of the phototype. So we talked about 1 and 2. So 1 is of the Irish, of the blue eyes, of the red hair, of the freckles, whereas 2 is a step down. Again, fair skin, blonde hair, white people. So one of the things with all of the dermatological of us examining it, us to let us know why we would want to look at that is the ABCDE. Asymmetry, border, color, diameter, and evolution. What did it start as? How long ago was that? And what it is now compared to. Distribution anywhere, okay? Most common for of the men with this is on their back, women of the arms and of the legs. Because of the fact that we're talking about the melanoma is more of a risk for the Caucasians. If it is having some things with those black Hispanics, the Asians, then that would show some of mucosals as opposed to everything that's on the outside. So if it's happening in some of the areas that are non-sun exposed, then we would think that it's more of the other ethnicities. That is the chart. It can show you on of the left side, that is all benign stuff. So we can clearly see of its symmetry, right? So it's a complete of a circular nodule, whereas on the other side, it's just not of a shape. So it's asymmetry. Border, we can see it on the left, but we cannot see it on the right. Color on the left is one of a color, whereas on the right, that is multiple or different of the colors. Diameter, it is larger, and evolving of that tiny, tiny picture, I think it's showing how it started at that size and then it's getting larger. More of the pictures here. The one that we're going to look at first is the ugly duckling. That would be the one, if that is of the largest and it is different than everybody else. If I show that that one is of a melanoma, if it's positive, then I would check everything else, okay? We would check everything else, but if that one is absolutely benign, we would still test out some of the other ones, but it's highly unlikely that it's not of a melanoma. So the ugly the ducklings, which one do y'all think it is? It's easy, right? What is it? It's that. Okay? So with these things, with of a diagnosis, what are we going to do? We're going to be using one of the dermalites, right? So that we can get into it and all have the pigments, the borders, the colors, and then also to mark of the areas where you would only be doing of a shave, of a biopsy, of a punch, or of excision. Primary care management, that is in bold and it is, underlined. What is more important for you to know is what will you be doing as a family practice physician assistant? What is it that you will do? You will start with the history of the ABCDEs. We're going to ask, is there pain? Is it itching? Is it bleeding, oozing, of that crusting? Is it a rodent ulceration? Do you have something in your house that bites you all over? History. Have you had any of the sunburns? Did you use some of the SPF? What is your occupation? Do you work outside and you're exposed to all of that? Are you on any of the medications that could be causing of the drug interaction? Have you ever had these before? Has your mom or your dad or some siblings? Are you also having some of the fevers, chills, night sweats, weight loss that are opposed to this? Again, you as of a PA, as we're doing the physical exam as well as all of the documentation, we will say it's of a photo type of stage 1 or stage 2 to go through those things. If you see something that you're concerned about and it's mucosal, then we could have a phototype of 5 or 6. TBSE. If I see this one here, if I see the ugly duck, then I'm going to look over everywhere else just to see if that one has of a sibling somewhere else and they're living in different areas, okay? As we're doing that, yes, we're going to stick with all of the face and the neck and of the trunk, but we also need to be looking at the palms and the soles, looking through all of the hair up top. We're going to be to look inside of the mouth and see that. Labs, CBC, CMP, UA. If you're ordering labs, those 3 are pretty much going to be in it every damn time, okay? Refer, 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 okay? Let of the dermatologist say, if you think that this is so severe, let that specialist chop it out. Part of the other reason why is because of the fact that it is of a melanoma, then it could not just be of a shave or of a punch biopsy. If it's going all the way down deep into of the dermis or even beyond that in a family practice clinic, we don't even have all of equipment to do those things if we think that we're going to win by here. Teach them of the self examination, which we talked about. Derm, once they go through some of the initial treatments, then they see those every 3 months, then it'll go 6 months after that. But again, refer, refer, refer. If you're seeing them because they have the hypertension, have you also seen your dermatologist, or you're not yet? Prognosis. So all of the curability is related to of the size and depth. Okay, so if it is when you have it, you have one of the ugly duck that has been there for years and years, and it's spread and spread and spread. Is there another that is out there that could be doing that of the same thing? We also have to think about the fact that it could have spread out. Breslow, which is what we're going to talk about right now, that is of the depth. Okay, so that is of the most important part of us to determine what the prognosis is. Okay, so is it, you know, up high, or is it all the way down to of our fat, and then of the risk are going to be way up high. With of the Breslow, we have of the Clark level. So it's talking about, is it only in the epidermis or all the way down to the subcu fats. So that is what it looks like, okay? You can see the depth as it goes down based upon survival rate of the prognosis. So if it's in situ, then you have a survival rate all the way up there. But if it's greater than the 4 millimeters, you're the half and half, whether or not you're going to survive. So yes, you can see those there. There are 4 of the histopathological types. So it's superficial, spreading, nodular, lentigo, and acral. And we're going to talk about all of these ones next. This is just the list of what they are. So let's start with the first one. So the superficial spreading, so SSM. Most common type of the melanoma. So if you have that, it is 70% of a chance that you have this. This can happen at any age, but it's most common in 30s up until the 40s. It can be anywhere, but it's most common on the upper back in both of the males and of the females. But if it's just an only woman, then it can be seen of the legs. Irregular, asymmetrical, borders. It begins as flat or elevated brown lesion, and this could be some of the nodules greater than the 2.5 centimeter. Hallmark is haphazard combo of many colors, more so with time. So if it is of an SSM, then it's been there and it's got of a combo of all of the medications. So it could be brown, black, pink, you know, it's all of the stuff that are looking alike. Asymmetric, irregular, brown to black. Typically, it's over of the 5 millimeters, and it evolves into black, blue, white, red, and undergoes the vertical growth. When it breaks down into these 4, the slides that show of the A, B, C, D, E are the most important ones specifically for that, because it's how it will be described to you, okay? So this is what they look like. So we can see some initial of a phase. It's flat. It's a little bit of a different of a color, but it's not a lot. As it's extending into the years after that, you can see how of the border is just going cray, and then some of the changes of the color. Then it just goes on and on, whereas of the bottom one, of the bottom 2 is having some of the vertical expansion up. So it's coming out to see you. Again, we have seen these numerous times, and that is just the breakdown of benign versus malignant. Pictures of the SSM. looks like that one right there is starting to have some of the vertical, right? So now it's coming up and out. Talk about the next one. So this is the nodular of the melanoma. Okay, oftentimes this will be 15 up to 20% completely of the vertical growth, right? So it's not the radial stuff, it's just jumping out to come shake your hand. Can occur anywhere, 40 up to 60s age. It is greater than of the male than the female. May not be pigmented, but the most common in color of a nodular melanoma is dark brown, or red black. Red black. Oftentimes this one right here is it's misdiagnosed, or it's not one of the things that you think it would be. Why? Because it's nodular, which we have seen with a lot of benign things. With the SSM and the other two of the melanomas, those are flat and out, but the nodular, oftentimes it could just be looking like of an SK, of the fibroma, all of benign stuff which we saw. Here it is again, dome-shaped. Border is irregular, brown to black, red to black, papule, nodule, rabbit-sized growth. Also, it can be of an ulcer. We can get some of the blood out of it. So, nodular. Pictures of it there. It breaks it down, so it could start off of a pretty one that just looks like a fibroma or something else. Then, as it starts to grow up, you can see of those things there. If it is of an angioma, then it's not just going to act the same way. Why is it of an angioma, right? Because it's not of the cancer. So I can push it into like it's of a pillow. Whereas if it is cancerous and it has all of the buildup in there, you can press on it, but it's not going to be pushed down. So here are some pictures of this one here. We can see the nodule there, but it's spread out a little bit also there. But it does have a nodule. Again, why I'm saying that is because the cancer is not only in of the nodule, but you can see the spreading of the asymmetry of the border all around it. But it just has a nodule. That one is spread and spread. Looks like it might be on the left side, forming another best friend. Nodular. Back of the leg. Back of the leg. All right, this is of the third one. Lentigo. Older patients that are of the age of 60s up to 70s. The face is the most common. However, we can see this also in the neck or the arms. Slow growth. So it's there, and then it's not just reaching out more for the worrisome thoughts, because it takes some time. It's not going to be just popping up like the nodule does. It grows quicker. Brown to black, raised blue-black nodules. It's not specifically of that, but it's not, it doesn't always have a nodule. 5% risk of becoming invasive. So it's moving down and up and around. There you can see, again, starts off at the centimeter, raises out, radial. So it's not only of a vertical like of a nodule one, it's more of the radial growth. Later on, once it's 20 years or so, then it can start to cause of a nodule, which is showing you right there. Face, upper cheeks. You can see some of the nodules there. I see 1, 2, maybe 3 on the lower of the upper lip. All right, number 4. So this is acral. Most common form of a darkly of the pigmented people, right? So we talked about last week about the nigra, right? So I talked about Morgan Freeman. That is absolutely benign, but if you see some stuff like that popping up, we still want to test it because they could have an acral, which is most common with the darkly the pigmented people. Palms, soles, phalanges, mucous membranes. Hutchinson sign. So it's the sudden appearance of a pigmented band originating at the proximal nail fold. So we're going to show you one of the pictures there. So it starts and then it spreads itself up and out, and it's a line. If you get this, the prognosis isn't well. So that is on of the foot. So it's on the sole. Here is that of the Hutchinson sign. So it's going straight up and down. It's not spreading out or that kind of stuff. Foot again. Foot again. Heel. Back up to phalanges. More phalanges. Should I keep saying phalanges with this one? Okay. Hands and feet. Okay, so here's just some of the things that is just to put together all of the things in regards to malignant of the melanomas. Okay? Early stages are diagnosed less often. Stage 1 was of a diagnosis in 39% of the DPP. Survival rates decline with delay in of the diagnosis. So if you're letting it sleep in your beautiful skin and it's not ever going to be excised, biopsy, tested, it's not going to do those things, then it's just going to spread more, and it could move around everywhere, metastasize, metastases. That's what happens. All right. 90% of the melanomas in LPP, again, the sun exposed. 67 of the DPP are not of exposed sites, right? Because we talked about with of the DP, we could have it under of the breast, of the groin, of those areas that are not. So LPP, sun, DPP, not. And y'all know just what I mean with all of the acronyms, right? Okay. It's those of the 4 ones. So LPP is more sun exposed, DPP is more that. The DPP are on the foot 40% of the time. Only 2% are on of the LPP on the foot. Subungual, mucosa, plantar, palmar, most common are in DPP. Total body skin examination. I don't think that we need to memorize the fact that it should focus on the hands, the fingers, the soles, under the tongue, and that. You're going to look everywhere, okay? But it only shows the ones on here because oftentimes some individuals will forget these ones because you have to do those ones as well. Instead of just looking at the face and the neck and the back and all of the trunk. If you are skipping of the sites here, you can have a high index. Educate. Educate everybody. Just because of the fact that you are of a Caucasian, of a just because of Caucasian does not mean that you cannot have a melanoma. We all can. Here's the slide earlier that was talking about the ABCDEF for the DPP. Age, 50s up until the 60s. Brown or black band, recent sudden or rapid development, digit most commonly involved, extension of brown the pigment onto the cuticle of the hangnail that goes all the way out. And we haven't just talked about the F, but it was added on there the family history, right? So you're just going to say Dad just had this exact same. So here it's talking about what advancement when these things are not untreated. So we're going to be going, if it's stage 1, if it gets more and more, how it goes all the way down. When the prognosis is very, very negative, then it could be all the way down with all the metastatic. Horizontal, if it's radial, that would have a better prognosis. So this one is not bueno, whereas the one over here, it can, have a different of a prognosis. The Breslow, we just talked about the fact that we would use one of the micro to determine what the prognosis is. So is it just on the epidermis, or are we getting all the way down into the fat? That would be, if you are trying to measure it out, that would be part of the documentation as you are referring them to a dermatologist. We talked about the fact that as we're having something that is of a Breslow that is significant, we also would have to check some the metastatic through the lymph nodes, and so that would be for something else for us to look at. More of the stages. So we have of a nodule up top that is going all the way down into reticular of the dermis. So it's all the way down, a score of greater than 3.0 millimeters. Getting all the way down, if it grows and grows and grows, then it's going to get into the subcutaneous fat, and the prognosis is no bueno. Again, this is all of the calculations of what it's like, right? So we're looking at what is of the thickness. Is it ulcerated? What is the age? Are they over 70 years old? Male or female? Lymph nodes, is there only one involved, or there's the entire chain that is acting up. Final thoughts. 80% of those arise on areas normally covered by clothing. 80% arise from areas normally covered. That is the reason why TBSE is one of the most important things. You, as the primary care providers, has the greatest opportunity to catch an early melanoma and make a timely referral to dermatology. Like I said, even if they're there because they have the shoulder pain, or they have their the shirt off, if you see something, ask about that and decide. Let's press it on. All right. We had 4 hours to do all of this, and it took 2. So, bueno. We are good to go. Do we have any questions before we step out? All right. I'm seeing y'all tomorrow at 8 o'clock, and we will get that done.